Welcome everybody to the launch of the Coverage Targets and Milestones, Ending Preventable Maternal Mortality. When people ask you what you did today, you'll be able to say that you went to an event that was planning to save lives of women around the world. My name is Femi Oke. I am your moderator. Thank you for spending this next 90 minutes with us. This event will be conducted in the 6 UN official languages. If you take a look at the very bottom of your Zoom dashboard, you will see a little globe there. Click on the globe and you will see the interpretation available. Click on the interpretation that you want to hear, and then you will hear me in 6 potential other languages. So, coming up, we will be looking at these targets and milestones for ending preventable maternal mortality. We will also be setting the scene. We will be hearing some official remarks. There will be a discussion as well. All of this involves you. We're not doing this for ourselves. We want you to be able to understand what is going on in this launch. So you see the Q&A box there. Put your comments, your questions right in the Q&A box whenever you have a comment or question. And then I will wrap it into the discussion as best as I can. There is a panel conversation coming up, plus your questions and answers. Answers from us, questions from you. So we get our event officially started with the UNFPA Executive Director, Dr. Natalia Kanem, and also the Director General of the World Health Organization, Dr. Tedros Adhanom Ghebreyesus. Welcome, Dr. Tedros.
To join the global community today to launch the milestones and coverage targets for ending preventable maternal mortality. These targets align with the recently released coverage targets and milestones of the global Every Newborn Action Plan and with the 2030 Sustainable Development Goals. An estimated 295,000 women die each year due to complications of pregnancy and childbirth. Most of these deaths are in low and middle income countries, and most of them are preventable. In addition, there are 2 million stillbirths and 2.4 million newborn deaths annually. And again, most of this could have been prevented with quality pre- and postnatal care and birthing assistance from competent maternal and newborn health professionals. But substantial barriers remain, particularly for mothers and newborns in low-income and marginalized communities who lack equitable access to care or receive poor quality care during pregnancy, childbirth, and the postnatal period. The COVID-19 pandemic has badly disrupted essential health services around the world, including for maternal and newborn care. WHO is supporting countries to resume these services regardless of a woman's COVID-19 status. We thank UNFPA for its partnership in developing these targets and milestones as we work together to make pregnancy and childbirth the safe and positive experience it should be for every mother and every newborn. I wish you fruitful discussion. I thank you.
Distinguished participants, dear colleagues and partners, on behalf of UNFPA, it's a pleasure to welcome you to this important launch of the new maternal health and well-being coverage targets for 2030. These targets and milestones will be crucial on our path to 2030. They're going to bring us closer to a world where no woman dies while giving life. Within the scope of Sustainable Development Goal number 3. The global community has committed to reducing the global maternal mortality rate to just 70 per 100,000 live births by the year 2030. If the current pace prevails, we will not reach this goal before 2065. This is a wake-up call for us to urgently scale up and accelerate our efforts. With less than 10 years to go, with the clock ticking, access to quality health care is not only essential for a woman's individual well-being, it's a key to ending poverty, to building human capital, and to creating robust economies. While we've made good progress in the past several decades, good isn't good enough. When more than 800 women die each day from pregnancy and childbirth complications, and many more suffer from morbidities, debilitating conditions such as obstetric fistula. Meanwhile, the burden of maternal mortality is borne disproportionately by the poorest and most disadvantaged women in low and middle income countries. Universal health coverage, including universal access to sexual and reproductive health care, will be key to providing equitable access to quality maternal health services. We are committed to helping countries achieve coverage targets by implementing action-oriented plans and by tracking progress at the national and subnational levels. The targets also incorporate key determinants of maternal health, including a woman's ability to make decisions about her own sexual and reproductive health. I am pleased to say that they're closely aligned with the Every Newborn Action Plan, the ENAP, as we cannot tackle maternal health without addressing newborn health. While the Ending Preventable Maternal Mortality Initiative can help us achieve our collective goals, tangible progress requires our unwavering commitment. May our partnership to end preventable maternal mortality be strong as the inseparable bond between a mother and her newborn. Thank you.
Thank you so much, Dr. Khanum. All right, so let us set the scene. Where are we right now with ending preventable maternal mortality? I want to bring in Dr. Anshu Banerjee. Of course, you will know him as the Director of the Maternal, Newborn, Child and Adolescent Health and Aging Department at the WHO. Anshu, good to see you. Where should we start?
Thank you, Femi, and it's a real pleasure to be part of the launch event today. I'll give a quick overview of EPMM, or Ending Preventable Maternal Mortality, its goals, its themes, and initial country selection. Merthe, maybe next slide. Next one. Thank you. And so when we look at where we are with maternal mortality and its projections, we know that the global estimates for the year 2017 indicated that there were around 295,000 maternal deaths in that year. And this was, however, 35% lower. This was, however, 35% lower than in 2000, when maternal mortality ratios were estimated to be around 451,000 deaths. The global maternal mortality ratio in 2017 was around 211 per, maternal deaths per 100,000 live births. And this was a 38% reduction compared to 2000. So the annual average rate of reduction in global maternal mortality over this period was around 2.9%. Now, this annual rate of reduction is far short of what is needed for us to achieve the SDG, or the Sustainable Development Goals targets, by 2030. Given the current pace of progress, it is clear that we are off track to achieve the Sustainable Development Goals. And of course, the COVID pandemic has also reduced the progress that we made even further. In addition, we need to expand the agenda around maternal health to also include health and well-being of women and their families, which will require us to look at health systems that deliver quality and respectful care, that look at how to protect women from catastrophic payments through financial protections as part of universal health coverage, and also that ensure equity by addressing the socioeconomic determinants of health. So our aim is that every mother, every woman has a positive experience of her pregnancy and has a healthy newborn. Next slide. Next one. I don't know, I'm not seeing the next slide. Thank you. Besides the average global target of maternal mortality ratio of less than 70 per 100,000 live births by 2030, which is the SDG 3.1, there is a supplementary national target that no country should have a maternal mortality ratio greater than 140 per 100,000 live births by 2030. And we also still have the silent tragedy of having 2 million stillbirths a year. The Every Newborn Action Plan has included a target that all countries should have 12 or fewer stillbirths per 1,000 total births by 2030, which is a target in the Global Strategy for Women, Children and Adolescents Health as well. For countries that have already achieved the target, it's important to close the equity gaps. And this also applies to the maternal health targets, whereby countries that already are less than 70,000, we do hope that they will be able to reduce their targets by another 2/3. And if they're already very low, that they're able to reduce the equity gaps within the country. Next slide. So when looking at where maternal deaths actually take place, we see that there is a lot of disparity across the globe. Maternal mortality is highest in humanitarian and fragile settings, such as in South Sudan or Somalia or in Central African Republic. But we know that approximately 80% of maternal deaths take place in Sub-Saharan Africa and in Southeast Asia. Success, however, is possible. The greatest declines in the proportion of maternal deaths occurred in Central and Southern Asia, where there was a gap or where there was a decline of 56%, and in Northern Africa and Western Asia, where there was a decline of 42%. There's, however, still a long way to go, because we have seen that globally we're off track to achieve these Sustainable Development Goals. Next slide. For this reason, the EPMM, or Ending Preventable Maternal Mortality Initiative, was launched in 2015, outlining the SDG target and strategies for ending preventable maternal mortality across 11 themes. And these themes include proximal and distal determinants, including social, economic, and political determinants to health and to access to services. So to date, EPMM has also been focusing a lot on strengthening targets and measurements, and this was the first step. Now, since 2020, the EPMM Management Group was expanded and currently is being co-chaired by UNFPA and WHO, and it started focusing more towards country implementation and support for programmatic in-country monitoring. The coverage targets and milestones, which we are launching today, were developed, priority countries were selected, and in order not to separate the mother-baby diet, as Natalia Kanem was highlighting, we are also working closely with ENAP, or the Every Newborn Action Plan, to create synergies for joint implementation and monitoring at country level. Next. So the 11 themes fall under 3 areas: guiding principles, cross-cutting actions, and 5 strategic objectives, and are looking at a multitude of things such as women's empowerment, girls' empowerment, integrating maternal and newborn health, and protecting that mother-baby diet. We're looking, for example, on how to ensure that there are adequate resources allocated for an efficient and health system. We're looking at how to address inequities in access, and also ensuring quality of sexual, reproductive, maternal, and newborn health care. We're linking up with universal health coverage to ensure that there is a comprehensive package included and that women and children are protected for those, and looking at strengthening health systems and also looking at strengthening accountability. Next. So the initial 19 priority countries that we identified were chosen based on a number of criteria, such as the burden of maternal deaths and stillbirths in that country, the presence of a partner in order to strengthen partnership at the country level to support the ministries of health. We're also looking at the different stages of the obstetric transition framework. We're looking at the strengths of midwifery at the country level, but also looking at diversity, looking at that from a geographic and geographic perspective. Next slide. So here you see the list of priority countries according to also the stage they're in within the obstetric transition phase. And this will allow us also to learn lessons with different health system settings, within different health system settings, and facilitate supporting countries as they move from one stage in the obstetric transition to the next. And the next and final slide of my introduction is just showing where these countries are and in which stage of the transition they are, just to give you a bit of a physical sense. Thank you very much, and back to you, Femi.
Thank you, Angie. Appreciate the overview. So this is the launch of the targets and milestones for EPMM. So let us get that launch underway. You will hear from Dr. Alison Moran, Dr. Willibald Zek, and Dr. Sylvia Deganis. Alison, get us started.
Great. Thank you so much, Femi. And it's great to see so many people here this afternoon. So I'm going to start out and talk a little bit about some of the coverage targets, and then will go and talk about the process we use to develop them and the way forward. Next slide, please. So as Anshu mentioned, we've been working closely with our colleagues on the Every Newborn Action Plan to ensure that we have some overlap and common coverage targets. As you can see here on this slide, the first 3 coverage targets are joint between the Every Newborn Action Plan and Ending Preventable Maternal Mortality. So the first indicator will be looking at 4 or more antenatal care contacts. The second indicator is looking at every birth, so births attended by skilled health personnel. And the third target is looking at every woman and every newborn, looking at early routine postnatal care within 2 days of birth. And as you can see from this slide, we are looking at tracking coverage targets that are measured at a global, a national, and a subnational level, so we can be sure to track equity as well as overall coverage. Next slide, please. So in addition to these 3 coverage targets that are common with the Every Newborn Action Plan, we've also developed 2 additional coverage targets that are specific to ending preventable maternal mortality. The 4th target, target 4, is looking at every pregnant woman with obstetric complications. And this mirrors the ENAP target, which looks at every newborn with complications or small and sick newborns. So for EPMM, we'll be looking at the proportion of the population covered by emergency obstetric care within 2 hours travel time. And then we've also be looking at a target 5 on the broader determinants of maternal health. As Dr. Banerjee mentioned in his presentation, the EPMM strategies document includes 11 themes, and these these other determinants that look at social, economic, political factors are very essential for the maternal mortality reduction. So target 5 is looking at women of reproductive age who can make their own informed and empowered decisions regarding sexual relations, contraceptive, and reproductive health care. And you'll notice here for these coverage targets, we're looking at both global and national level targets. Next slide, please. So just want to talk a little bit about the proposed principles and how we came up with the development of these targets. So as I mentioned before, we wanted 4 or 5 targets that would be common with ENAP and also look at management of obstetric complications and on the broader determinants of maternal mortality reduction, relevant to all of the 11 themes of the strategies document, and very importantly, are feasible to measure. There are a lot of things that we'd like to measure, but where we are right now, we wanted to ensure it was something that were feasible to measure and what we can really track over the next 5 years. We also wanted to push the envelope a little bit to be ambitious, but also ensure that we would have enough data, ideally through routine data collection systems, to be able to track the indicator. In addition, it'd be important for use for advocacy, similar to our colleagues in immunization and HIV/AIDS, to create a story about where we are with tracking progress toward ending preventable maternal mortality, sensitive to change over time with a programmatic focus, and would really provide a complement to the mortality targets that Dr. Banerjee mentioned before, as well as the milestones, which we'll hear about in a few minutes, at various levels, including at subnational level, to address equity. So now I'll turn it over to my colleague, Dr. Willibald Zek, who can talk a little bit about the process for how these targets were developed. Over to you, Will.
Thank you, Alison. And my name is Will Zek. I'm working in UNFPA HQ, leading the UNFPA's maternal newborn health program. And as you've heard from Alison, there has been really a lot of progress. And just to give you the gist also of the process, because there was a process behind it, a very good, we believe, good and firm process. In May, September 2020, we did an initial mapping of the possible EPMM targets. And you see that there were many partners involved, also the EPMM and ENAP metric group. Then in September, October 2020, we did a first consultation, a second consultation in January, February 2021. And in between, we had 86 responses from 40 countries, including 36 organizations. And then we went on in June, from March to June, to do consultation results and consult with EPMM ENAP metric groups. And as you see, we are now here at the launch. So you see, we've been working on this since quite some time. And I think we can also be proud of also aligning EPMM and ENAP metric groups with what we're presenting here with our targets. Next slide. And you know, the WHO, UNFPA, and UNICEF will also develop an operational guidance on how to collect these coverage targets. This is planned for 2022. There will be also a live EMONG survey tool on target 4. And then we will also adapt the ENAP tracking tool to incorporate EPMM targets and milestones. So there's alignment and also track progress for implementation. So countries will report on the targets and milestones on a voluntary basis in 2023 and 25. Just to say that this is not a mandatory, but really a voluntary process that we are proposing and that will be going on in the coming years. And that's from my side. And next slide, please. I would like to hand over to Dr. Silvia de Ganas to talk about the overarching milestones that any country can adapt to their own context and that will be guiding assisting countries in achieving the targets. Dr. Silvia is an accomplished obstetrician and gynecologist, public health physician who is based in Ghana. And over to you, Silvia. Thank you.
Thank you very much. As you're all aware, as you embark on any journey or any endeavor to reach a certain target, you need to look out for certain landmarks that will help you identify whether you're on track and what progress you're making. And for that, we have come up with 10 milestones. Now, these milestones are to support countries to identify gaps and barriers and jointly create action plans that will help them address the gaps. Because if you don't know where you are and where you're going, you are not able to plan. And more importantly, help them identify the specific areas of need for support. Next slide. Next slide, please. Now, we went through a process of developing these milestones, and we've been working on them since December 2020. The first step was to identify the areas of focus we were wanting, and this took place in December. In January to March 2021, we were able to develop a set of draft milestones, and these were reviewed by the steering committee between March to April this year. Now, after that, we're able to send this draft to countries where we had a number of countries looking at the document and giving us suggestions. These were fed back into the final product in August 2021. And today we are here proudly to launch these milestones. Next slide. Now, in doing this, one of the key considerations we did was to look at the complementarity between the Every Newborn Action Plan and the Ending Preventable Maternal Mortality and Morbidity Milestones. We did this because we recognize and appreciate the mother and baby dad, and that care is often given to both at the same time, and also to ensure that there was uniformity. And looking at the ENAP milestones and how they complement the EPMM milestones, we recognize that the 9 ENAP milestones actually were very complementary to the EPMM milestones. There was just one that was not captured, and this related to the issues of equity. Equity, especially being important in universal access to care. And so this is one of the new ones that we have included in the EPMM milestones. Next slide, please. So our 10 EPMM milestones, which we are presenting today and we are launching today, include milestones on policies and plans, milestones that are looking at quality of care, looking at data, investment in maternal health care, the workforce, and response and resilience to challenges. Now, we're also looking at commodities, areas of accountability, research, innovation, and knowledge exchange. And as I've already mentioned, equity was the 10 that we have added on, which differs from the ENAP milestones. Now, these milestones can be applied both at national, subnational, and global levels, and will help us achieve the targets. Now, it's also important to note that these milestones will enable us to monitor progress towards the targets that have already been presented, and will enable countries to achieve improved maternal and perinatal health outcomes, and hopefully achieve the SDG targets and global targets. I think I would end here with this slide and say over to you, Kemi.
Thank you so much, Sylvia. So at this point, our 3 presenters are all relaxed now because they finished presenting. They do not know that you have been asking so many great questions. I'm going to bring them all back. So Alison, Will, Sylvia, don't go and get a cup of tea yet. You are not done yet. I'm going to bring you back from the big Q&A, but we've got some instant questions here. Sylvia, for instance, our viewers would like to know, will those slides that you presented, will you share them?
Yes, I would like to share them.
All right. Well, that was an easy question for Sylvia. Sylvia, don't go away. We'll bring you back a little bit later. Dr. Moran, Alison, this one is for you. This one is from Jennifer Stevens. Thank you, Jennifer. Alison, are you using the WHO definition for skilled birth provider?
Yeah, thank you very much, Femi, and thank you, Jennifer, for the excellent question. Yes, we are using the official SDG definition for skilled health personnel to monitor that coverage target. And as Will mentioned, we will be developing some operational guidance that really gives a lot more detail about how each of those indicators is defined, the numerator, denominator, as well as how the targets might be calculated at global, national, and subnational level. So look forward to get more inputs on that as we start with that process.
Okay, great. And then one more for Will before we move on with our panel discussion. Will, this is a question from Dr. Hala Yai, and wondering why Myanmar is not included in the priority countries. Our MMR is 250/100,000 LB. The direction I want to put you in is not particularly why Myanmar is not included, but who is able to use the targets and milestones. Will, go ahead.
Thanks, Femi. Just to say that we had to start somewhere, because this is really the first time we are engaging with country implementation, and so we had to be a little bit. We had to select regions, then we had to select also the capacities that are there, and then also whether there's an opportunity to engage and also willingness to engage. So whoever is not on the list, please don't think that you are not listed or you cannot use the targets and milestones. Of course you can, but we had to start somewhere. And as we go on in the coming years, the numbers of countries will increase. And if there's interest, of course, you can reach out directly if you want to engage further. But just to say, no, this is just a first set of countries we had to choose, and the choice was very difficult. But there will be more countries and we will increase the number of countries, no worries.
Thank you, Will. Thank you, Alison. Thank you, Sylvia, for your presentations, for also doing the speed round of questions. I will get you back in the Q&A, so you will still be available. Nice to see you, viewers. Thank you for being part of this launch of the EPMM Targets and Milestones. If you've just joined us, you may not know at the very bottom of the screen on your dashboard, you'll see interpretation in 6 of the UN languages. Please use that if you need to use that. And then also, as you've just seen and heard, you can put your questions in the Q&A box. That's very helpful because it's easy for me to see, or you can put your comments in the chat, and we will do our very best to include those comments, those questions into this session so that you go away with more knowledge. And that is the whole point of this. Now, you may remember, you were right at the beginning, Dr. Tedros from the WHO said, "I wish you a fruitful discussion." This, hopefully, is about to be the fruitful discussion. We're looking at advancing maternal and newborn health in high burden countries with experts from around the globe. I'm going to say hello to Dr. Martina Baye, Dr. Saroja Pandey, Nick Pearson, Taraya Adams, Franca Caddy, and Robin Churchill. They are going to introduce themselves to you and tell you why they are important to this conversation, what they're bringing to the table. Martina, please, you start first of all. Please introduce yourself.
Thank you, Fen. Hi, everyone. I am Martina Baye, public health physician, presently coordinating the national program to combat maternal, newborn, and child mortality in my country, Cameroon. I've been into this adventure, trying to reduce maternal and child mortality for the past 20 years. So I think I've gone through a lot, made mistakes, either in the system or personally, and I've learned lessons which I hope to be able to share. But most of all, be able to learn from others so we can continue improving what we're doing. Thank you.
Thank you, Dr. Martina. Dr. Saroja, so great to have you here in our panel. Introduce yourself.
Thank you, Femi. I am Dr. Saroja Pandey from Nepal. I worked as an OBGYN, and I had an opportunity to work as a service provider as well as a trainer, and also as a professional society's active member. I work with the policy makers. Thank you so much. Over to you.
You're so welcome. Nick, so good to have you in this conversation. Tell our audience who you are, why you're important to the conversation.
Hi, my name is Nick Pearson. I'm the founder of Jacaranda Maternity and executive director of Jacaranda Health. Jacaranda Maternity got our start 10 years ago with the belief that all women, rich or poor, deserve safe and respectful childbirth. And my Kenyan colleagues and I set up a maternity hospital in peri-urban Nairobi that provides affordable, empathetic care for working class moms. We can talk a little bit more about it later, but in the meantime, we also work in close partnership with the Kenyan government in public sector facilities as well to improve equity and access. Happy to be part of this.
So happy to have you. Taraya Adams. Taraya, welcome. Introduce yourself, please.
Thank you. My name is Taraya Adams. I work as the Senior Communication and Advocacy Officer for the Right Ribbon Alliance. And a big part of my job is working with women and the communities to tell their stories and their demands for quality reproductive health. And the perspective I bring to this conversation is the voices of those women whose voice cannot be heard. And I'm thinking in this panel, they will be heard. Thank you.
Absolutely. Hello, Frankie. Good to have you. Please introduce yourself to our global audience.
Great. Thanks very much, Femi. Yes, I'm Frank, as you said. I'm in my second term as the ICM president, but I identify myself as being a midwife. And as I'm sure you all know, midwives are healthcare professionals, but actually more than that, I think we're sexual reproductive health and rights advocates. And like most midwives, I'm very, very passionate and I think a bit annoyingly persistent. but I think that midwives need to be, because I think the evidence for midwifery is so clear. So I'm here for the voice of midwives to be heard so that we can play our part.
So glad that you're annoying. Excellent. Robin, good to have you. Welcome to our conversation. Welcome to the discussion. Please let our audience know who you are, what you do.
Thank you so much. This is a very exciting opportunity and launch of these targets. I am a nurse midwife, which I think you can never not be. And I think that's one of the reasons that I do what I do. And it's also where I feel very much that the voice and the perspective of midwives is important. I'm also the maternal health team lead for USAID. And I think as from the donor perspective, we want to hear voices. We need to hear voices. We need to take the lead from countries and support this work and the operationalization of these targets. So that's what I'm here for. Thank you.
Thank you, Robin. My challenge to our panelist audience is that they all bring a story. We have heard about statistics, we've heard about numbers, targets, and milestones, but where are we rooting our conversation in the lives of women and families and children? So that is the challenge that I'm giving our panelists, and also to interact with each other. I see all of them. I can see absolutely all of them. So as soon as they have something to add, I'm going to bring them into the conversation. And of course, you have your Q&A box, the comment box as well. You're going to be part of the conversation as well. It is mandatory. Now, this is something that rarely is heard. We are going to start with civil society. Usually civil society is right at the back. No, come forward, civil society. Taria, you said you wanted to bring the stories of women that are important. Give us one story to get us started, to get us into this understanding of how do we advance maternal and newborn health in high burden countries. What story would you share with us? A short one to start.
2 months ago, I started to shoot a video to tell the stories of women and girls. And Halima, a lady 28 from Niger State, who was to deliver in the facility, was told to bring water, a keg of water while she was in labor to a facility. And on her way to bring the keg of water, she had her baby on the road. Those are the voices of women who, this is beyond the clinical lens of what happens in the facility, but what are the other factors that prevent women from receiving quality care? Are we just talking about clinical issues that happen at a facility? Are we going to look at the broader spectrum of what happens even before the woman goes to deliver? Those story, Halima is not alone. There are many women like her whose voices need to set their agenda and decide how these conversations go. Thank you.
Taria, did you hear in the presentation that the voices of vulnerable women and girls were being included in the targets and milestones? So is that your job to make sure you take those targets and milestones and then add those voices, include those women in the strategies?
I was super excited when I heard that. And then I was super excited when I heard the milestones have equity, because these women are demanding equity. And I think it's time, and it's great to see that in the slides and to hear that also, that equity is being considered in these conversations.
Where are the gaps from your perspective, from the work that you do in terms of equity?
I think from my personal experience working with women at the community and leaders, decision makers, the gaps of really where what decision makers think should be done and what the women think should be done. And the big question is, who's setting these agendas? Whose voice defines what should be done? And how will those voices also monitor what is done, the implementation of what is done? I think the gap really is about who decides how this conversation should be, what should be implemented. If women set their own agenda, the women will bear the burden of reproductive health. If they set the agenda, if policymakers can close the gap by bringing in women to set the agenda, then we'll begin to see much more progress than we're seeing, I think. And I think we're doing a fantastic job. We need to do much more by bringing the voices of women.
I wonder what you would ask a policymaker. I'm going to bring in Martina. Martina, I'm going to put you in the category of a policymaker. Taria, what would you ask Martina as a policymaker? What is your ask?
Martina, Haliba in Niger State and every other woman in Niger States or across in rural communities want a system where they are part of policy designs, where their voices shape policy and implementation of programs. That's what they ask, and that's what I bring here.
Martina, go ahead.
Absolutely, Taria. And let me start by saying a short story. This is on the positive side, but which shows how, you know, the women's or civil society voice is really important. Cameroon put in place a strategy called the pre-positioning of obstetric kits in our hospitals. And there was, I'm talking about a man here, but I mean, we're talking about a family. This traditional ruler who decided that any man who allowed the wife to deliver at home instead of taking her to the hospital, where he would pay 6,000 francs CFA. If the wife delivers at home, the man would pay 10,000 francs. So this is somebody from civil society who's really supporting policy that government has put in place in order to make sure that families' voices are actually heard. So, and the other one is when we put in place the health voucher in order to subsidize healthcare, the very first women that benefited from this care, I heard one of these women say, "At last, what have we done to merit this kind of good treatment?" It broke my heart, and it still does as I speak now, to see that, you know, not allowing these women to say what they want, what they need, you know, really makes them suffer. So I think civil society should and is part of our policy making in Cameroon. Hopefully that should be the case in other countries too. Thank you.
So EPMM is an SDG target. And how are you in Cameroon, how are you on track for achieving that particular target?
I won't say that in Cameroon we're on track presently, but we're very conscious of the fact that we need to accelerate our efforts. Let me just say here that between 2011 and 2018, Cameroon reduced its maternal mortality ratio, according to the DHS, by 40%. That's very encouraging for us, but we need to align to this target that we've just listened to today, and make sure that we have robust plans that will enable us, you know, follow up closely to see whether we're really getting to this target. Thank you.
Franca, go ahead. What did you want to add?
I just wanted to add something about the institutionalization of birth. I can really understand that we want to support people or women to give birth in institutions because we could give quality care. However, we do have to make sure that women then feel at home in those institutions. And I don't think that we as healthcare professionals often welcome women to be at home in our institutions. And I think that would really change kind of the respectful care that we give. We need to start building trust. We need to go to the human level, not to the technology level. It's not the institution that actually supports the woman, it's the people in the institution. And so we have to be so careful when we say we want to institutionalize birth, then make those institutions home-like so that women actually want to be there.
Taria, you have a thought. Your hand is up. Go ahead.
Yes. I really just would quickly comment, Franca, for that. And these are some of the things that women are saying. Women are saying they're uncomfortable in some of these facilities. Also, I wanted to bring an example of how women's voices have set the agenda and have delivered results. Recently, WRA Nigeria launched the What Women, WRA Global launched the What Women Want campaign. And in Nigeria, the number one thing that women asked for was wash. Women wanted cleaner facilities. Yes.
Oh my goodness. I've got a question for you about exactly that thing. Finish your thought. I'm bringing in the question. Go ahead.
Okay. And so we reached about 80,000 women in Nigeria and globally 1.2 million women to tell us their one reproductive health demand. And in Nigeria, women said wash was their number one priority. And so we took the demands of women and we started some advocacy work around that. And currently in Niger State, they're implementing what they call the Basic Healthcare Provision Fund. We went to community leaders to say, these are the things that your women are asking for. As you're implementing this fund, why don't you look at providing water for some of those facilities? And the community leaders listened to us. And now we have 10 facilities that have water. I don't have the data of increase of women going to the facility, but it shows that women can set the agenda, and this agenda can then translate into action if we listen to women. And also COVID-19 showed that really women knew what they were saying. If women were asking for water in 2018, in 2020, COVID happened, and water became one of the most important things in our facilities. And I think it's an example that we should listen to more women, you know, we should bring women more to the table. Thank you.
Nick, go ahead.
The points that Soraya and Franca made just really resonate with me. I think one of the things as a sort of private sector player, as we were setting up our own maternity hospitals, a big part of it was the design of patient-centered care and patient-centered design, incorporating the voices of the moms into the design of the services and the sort of protocols. But I think one of the points I wanted to make is that, you know, oftentimes private sector is thought of as this sort of extender to government health systems, when I think it's also important to recognize in the context of these EPMM targets that the private sector can be a really important kind of innovator and partner to government in improving how we deliver care in the government health systems. And I wanted to use an example of that. Our sister organization, Jacaranda Health, partners really closely with the Kenyan government on improving outcomes in the public health system. So we're working across hundreds of large county hospitals. And one of the things that we do, and this sort of ties together some of the points that Robin was making about data and also some of the points about respectful care, which I think is so important, is we have a digital health platform called Prompts, and it enrolls women in these public health facilities during prenatal care, postpartum care. And the idea is there's sort of 800,000 women already who are enrolled in this platform, you know, maybe a third of the women who are pregnant in the country. They're enrolled in public facilities and they receive sort of messages, and the idea is to sort of link them to care, change health-seeking behaviors, improve sort of ANC, uptake of postpartum family planning, et cetera. But one of the things that we found has been really interesting was with a platform like this that's operating at a large scale is it gives women a voice in the health system. So all of those moms receive surveys on a regular basis, and particularly about how they received care in those public health facilities. You know, as we know, there's not often an opportunity for folks to have a voice in describing the care that they received in terms of like disrespect and abuse. And we're able to sort of digest that information that comes back in and disaggregate it and share it with our government health partners and be able to say, hey, you know, in this county, here's your rating, here's how you're doing, here's how women are telling you this is. And what's been most exciting to me is that the government, the county health partners that we work with are actually using that data. They're putting into the practice. They're saying, hey, this sub-county is underperforming on sort of the respect indicator. What are we going to do about it? We'll send teams into the facility. So it's kind of a cool sort of you know, tie-in of how both sort of data and respectful care can be used together in partnership with the government.
Nick, I've got a comment from you as you've been speaking. Private sector sometimes look only at making money, not the perspective of the women. Poor women cannot have access. In the case of Jacaranda, what would be your pushback? How would you say, no, we are an important part of maternal health care?
That's a great point. And there's certainly that thread that's a common thread in the private sector. But I think, you know, one of the things that's important, because equity is so central to this agenda, that private sector players are increasingly linking in with government health insurance schemes. So for example, in our private maternity hospitals, we take the National Hospital Insurance Fund so that moms who have public insurance are able to get care sort of without paying out of pocket, which is really important for access. But this is part of the reason, honestly, why we're also working with the government, because really, if you want equity, you need to be reaching folks at the last mile in rural counties, et cetera. And so we're working very closely with these sort of county governments that are serving folks using technologies like SMS that are broadly accessible. So I think, you know, it's more, it's definitely a criticism that is fairly leveled sometimes at the private sector here in the US, where I'm from originally. That's clearly a problem that creates barriers to equity. But I do think that the private sector can be a sort of a thought partner in some respects about improving financing, improving access and equity.
Thank you. I'll come back to you anytime you put your hand up. All right, Franca, I love the way that you describe midwifery. Like, if it was a pill, can you expand on that? The idea of where the practice, the skill, the professionalism of midwives, how that helps us is obvious. I don't even want to finish the sentence about what our panel is about increasing maternal health care, increasing the outcomes of women coming out of giving birth, and they're alive and well and healthy. Go ahead.
Thank you. Well, midwives are predominantly women doing women's work with women. And we are one of the oldest professions that has existed. And as I said before, we're very persistent. I think that what midwives do is we have a very broad practice, and it really varies from country to country, but it's known that we can do up to 90% of the sexual reproductive health and rights care. And midwives work with a combination of kind of head and heart. We work with a combination of being highly skilled when we are, of course, educated to international standard and supported to be able to work well. And at the same time, the evidence shows that when we work with continuity of care, so when we build a relationship of trust, which in many ways sounds so logical, but when you build relationships of trust with people, then you actually manage to give much more better qualitative care. And what I love about these EPMM indicators is that we are talking about quality, respect, equity, all at the same time. That's what midwifery is. Midwifery does the combination. And that is the reason why I really think, and I've said to you before, if midwifery were to be a pill, I know it would have been given to every single person in the whole world. But midwifery is not a pill. Midwifery takes time to implement. Midwifery is a long-term solution. But at the same time, you will really get your money for what you invest in it. It is really a solution that will give us long-term benefits, but it's not a quick win. And I think that it really needs us all to invest in midwives and support midwives in teams, of course. We need obstetricians too. We need nurses. We need all kinds of people. And most of all, we need to listen to women. And I would hope that midwives too, because if you build relationships of trust, would work with women. The word midwife actually means with woman. It's our only reason for being.
Kristen Graham says, thank you, Franca. Your midwifery voice advocating for women is so wonderfully appreciated. Saroja, you're listening into this. What's going through your mind? Come into the conversation.
Definitely, as Franca said, the long-term solution is for the quality maternal and neonatal health care is the midwifery. But in the so many preventable maternal death, who have the high burden of the preventable maternal death countries, they are still struggling with the number of the midwives. Like we have a very small number of the midwives, but the long-term plan is definitely producing a sufficient number of midwives for the quality of the care. And the collaboration and the shared accountability between the midwives and obstetrician and gynecologist will be very effective for the quality of care and the safe delivery. And that will lead to to achieve the SDGs in time, and for our part of the country, it will be very effective.
I'm just wondering where you feel the gaps are, because the whole point of the milestones and targets is to fill in the gaps, because bit by bit by bit across the world, the number of maternal deaths in childbirth they've gone down. So it's going in the right direction, but not fast enough, and not certainly to reach the targets by 2030. Where are the gaps, Saroja? What would you do first?
I think the gaps lies differently in different countries. And definitely we achieve a lot in these MDGs also. And we are already far ahead in the preventable maternal deaths, but still we have to go very far. And there is definitely a gap, but the gap is mainly in the quality of care. And there is no equal services, maternal neonatal health service across the countries. We have to reach unreachable in the remote areas and in the community level. Mostly the city areas and the urban areas, they have sufficient maternal neonatal health service providers and all the services there. But the community level and the remote areas, still they have gap. And still there is some lacking between the so-called collaboration and the shared accountability and timely referral. I think we have to now work on the quality of care and the accountability and the sustainability of the trainings in those service providers who are working in the far remote areas.
Mm-hmm.
Definitely it varies among the countries.
Martina, please go ahead.
Thank you. Just to add to that, we need all sorts of resources to be able to reduce maternal mortality. The most important of us is the human resource. So I just want to add to what Franca was saying. I think ideally in any of our countries, the midwife should be at that primary level of the community, because that's where he or she works to prevent complications, make sure that during pregnancy, these women receive the best care, and during labor and delivery, that complications don't develop. So this is very important resource for our government should actually be found, first of all, at the periphery, where they'll reduce these complications that may lead to death. Just wanted to add that part of it.
Okay. Franca, and then I'm going to go to Robin. Oh, Robin's hands off as well. So, okay, I'm definitely going to do it in that order. Franca, then Robin. Thanks for your patience, Robin.
I'm so sorry, Robin. I'll be quick. We are really a lot of midwives short. The State of the World Midwifery Report showed we are 900,000 midwives short. Midwives get just about one of the lowest pay for the type of job that we do. And we are not in leadership positions. So just like women are saying they want to be at the table, we want to be at the table, and not only at the table. We want to speak and be heard and be listened to and it acted upon. And that will really make a difference. And in the patriarchal system that we're working in, often people want midwives to do the work, but they don't want us to say how we think it should be done. And that needs to change. That paradigm needs to change. We need to have equal teamwork and not patriarchal teamwork where we're just doing the work, but actually following other people's orders. We know what is needed, and midwives need to be listened to. Thanks.
What do you feel the flames coming off your screen, everybody? That's the truth bomb right there. Franca just dropped it. Robin, welcome to the conversation. Go ahead.
I've been listening to these themes, and I will say that thinking about what Nick has said about digestible data, where Franca's whole point about being in, like, doing the work, but not helping think about how the work is done. Dr. Austin Dembe wrote in the comments the question about, well, what about technology? If you don't even have a touch screen or a touch phone, how do you do this? And Martina's point about the fact that there is this human resource gap. I sat with in a district health office with a midwife, a nurse midwife who had clinical skills but was in a management position. And we talked about the need to have good data to actually improve services. And she said, oh, here is my data. And she sat behind 1/2 meter of paper. And she said, these are the narrative monthly reports from each of the health facilities. And I said, well, how many months is that? And she's like, oh, 6 months. Of course, she hasn't read it yet. So then we talked a little bit, well, what about Excel and databases? And she shows me this other admittedly smaller pile of paper that were the printed out Excel sheets. Also, she says, oh, I'm 3 to 4 months behind on that. So it's great to have good data. It's great to have the wealth of information in these narrative reports, but to what end? And I think this is one of the pieces we've seen time and again. We say it's too expensive to have digital systems, but I think it's imperative to have data that's useful. And instead of searching for the perfect indicator, we must make use of the indicators that are of the data that we have to best have these indicators that matter. We can improve it over time. But if these midwives are already being taken out of clinical positions, please let's make them make good use of their time, make good use of management's time, give them data that is useful. I think these targets are excellent. Having the subnational data is wonderful, but if it is not being used in real time, if it is not useful at every level of the health system, we cannot make improvements. And that is really my point. Thank you.
That donor voice in the conversation, Robin, where should funding go?
This is where I think that we need to be working with ministries of health. We need to be working with countries, and it can't just be a one-off here in our project. We will fund a digital database. It has to be part of an infrastructure across the public sector. And Nick, I'd be really interested to hear how the work that you've done in Kenya, because I think the private sector has to be part of it. There has to be a way that private sector data, particularly in countries where the private sector does so much of the care, it needs to be integrated, and there needs to be some good full country systems that are driven from kind of this policy viewpoint, from a national viewpoint, but with a lot of that input from the ground, whether it's civil society needs to have some say in it. Certainly the midwives, the health workers it needs to be useful for them. I think that from a donor perspective, those conversations are the ones that we need to be inviting and hopefully invited into, so that we can be strategic in how we support the development of those systems.
Nick, your name was mentioned. Go ahead.
No, those are great points, Robin. And I think, I won't go into the sort of details of digital health and data infrastructure, because I could talk about that for a long time. But I do, one thing that strikes me from the conversation is that, I think the EPMM targets are fantastic because they signal a commitment. It's at both a country level and a global level towards achieving targets, and that is critically important. It's the kind of why and the what. I think what also is important in this process is thinking about the how, and whether you want to call that implementation science, or whether you want to call it innovation, or whether you want to call it sort of iteration, that oftentimes that's where, at least in my career, that's where I've seen some of the gaps in, whether it's the 3 delays, or it's not just about kind of making a commitment. And, we have commitments to equity. I think in Kenya, for example, the government's taken a really strong stance on making maternity care free for all, which was a huge win and a leap forward in terms of improving access to care. Really commendable. But there's still, in all countries that, that we work in, and there's still these kind of gaps in figuring out, okay, well, we know this is the goal and the target that we want to set. How do we kind of innovate and improve incrementally and work towards those? And those take kind of partnerships. It takes partnerships with researchers. And I think it requires a degree of kind of collaboration around the how.
Panel, some of you have your hands up. If you've already asked your question, take your hands down so I know who actually wants to ask a question. Martina, go ahead.
Yes, just from your advice funding, though, I would say it starts with country-led, government-led, action plan, strategy, operational, with everybody around the table, all stakeholders, including the donors, as Robin was saying. Then from there, we all know that each donor comes with a comparative advantage. So once everybody's around the table to developing the plan, then you now just fit into where you feel most comfortable. But it has to be agreed that we have a common plan to which we all want to contribute. Just wanted to say.
Thank you. Taria, did you have your hand up for the last time, or you've got a new question or new intervention?
I've got a new comment.
Very good. Go ahead.
Franca, I wanted to support your view. Midwives' demands are women's demands. Women's demands are midwives' demands. We're currently running a campaign in Nigeria and in some of our countries in partnership with the International Confederation of Midwives called Midwives' Voices, Midwives' Demand. And we did an assessment in one of the states in Nigeria. Interestingly, the government did not know the number of midwives they had. And when we did the assessment, it was shocking to find that there was only 64 midwives in government employment in that state. We brought back the data following this year's team for the midwifery year, followed the data, invest in midwives. And when we brought the data back to government was in shock that they had only 64 midwives being paid by the government. And so this is why it's important to use the data and use it wisely. And even for the 64 midwives they are, a lot of midwives had been moved to administrative tasks. And so they had few midwives, a lot of those few midwives were not performing their actual duty again. And so this is where it's important that we follow the data, and I love the EPMM targets, because it allows countries to make commitments and to follow this commitment. And it's important to have civil society in these conversations to hold governments accountable, because accountability is a big part of these conversations. As we all know, governments are always excited to make commitments at global level, but at subnational level and national level, the realities seem to be different. And so I'm really, really excited about this conversation. I wish the Minister of Health for Nigeria was here so that he could hear those commitments and then take action. Thank you.
Franca, Graciela Bernardo says, excellent, Franca, exclamation mark. What else do you want to say, Franca, before we go to a general Q&A? Go ahead. Franca, please go ahead. Unmute yourself. Is Franca with us? Have we lost Franca?
No, I'm here. I'm sorry.
Yeah, there you go. That's all right. Go ahead. You were basking in the praise.
Well, it's not me, it's midwives, I think. And midwives are not the golden bullet, by the way. I think it's the systems change that's the golden bullet. But we do have some issues with data, like Taria is saying. Often countries don't know how many midwives they have because they're registering skilled birth attendants. And it's kind of like all kinds of different cadres. And I think it is important to start registering how many midwives there are according to the international definition of a midwife, so that we actually know how many midwives there are. And I think one way of doing that is to make sure that we get chief midwives in ministries of health. I would really like to call on every ministry and WHO and UN and everyone, get yourself a chief midwife, because then you get that voice, and maybe a chief midwife with a chief woman next to her, because maybe we should be doing it together.
All right, there are so many questions, panelists and presenters. You really inspired a lot of thoughts, a lot of questions. I'm going to ask you to tackle them as swiftly, efficiently as possible. If you can answer the question rather than me volunteering you, put your hand up. I'll also be looking to our presenters. So Sylvia and Alison and Will, put your cameras on so I can also see you. And let's get started. Let's start with Lily. Lily, I love this one. Is nutrition a contributing factor in maternal mortality that should be considered? Who wants to take that one? Anshu.
Femi, yes, of course it is, and particularly anemia. So micronutrient deficiencies, and we know that anemia is a major problem. It's important for the growth of the child. It's also important for the well-being of the mother. And if there is postpartum hemorrhage or antepartum hemorrhage, it's of course very important that the mother has sufficient blood to be able to, let's say, buffer that shock. So nutrition also for deformities of the baby, folic acid, for example, is a micronutrient that's very important. So nutrition is a core component of being a healthy mother and having a healthy baby afterwards.
Taria, your take on nutrition? Taria, go ahead. Your hand is up. Unmute yourself.
Oh, my hand was up from the other.
All right, put your hand down. All right, panelists, don't confuse me. All right, let's move on. This is from Jenny. Jenny, thank you. Yes, we will share the slides and we'll work out a way to do that. Team, can you put in the chat how people can get hold of the slides? Because we have said we will share the slides with them. And so that would be very helpful. So anyone from the team, just jump into the chat and do that. Okay, how helpful is it to have interim targets for 2025 towards achieving SDG 3.1, which is the SDG that connects most directly with EPMM? Interim targets. Will, do you want to take that one? Is it useful to have those interim targets?
Yes, and I think especially with the COVID-19 crisis, it is even more important that we monitor closer where we go and how we go. And also the United Nations in general, they have now come up with our common agenda. This is another roadmap that goes parallel with the SDGs, also adhering to COVID-19. So everyone is in the process of adhering to that. So, as we come out of the COVID-19 pandemic, we don't even know how many lives we have really lost indirectly and how many women have not been able to access services also with the newborn. So even more important that they do a closer monitoring. And that's why we thought also that this launch and the milestones and targets are very timely, because it really helps us to monitor better and see how we go towards 2030.
Thanks, Will. Betsy McCallan, thank you, Betsy. When we speak about equity, we cannot only talk about urban and rural, but also about different populations, including adolescents, with adolescent pregnancy on the rise in many countries during COVID for a variety of reasons. What are your views on strengthening this aspect of EPMM? So equity that's about different populations. Martina, do you want to take a look at that? Because you're dealing on a countrywide level.
Absolutely. What we do, let me share what we're doing in Cameroon. We've of course noticed that young people, despite the fact that they need healthcare, they don't go to the hospitals easily. And on talking with them, we realize that they kind of feel, afraid, or they don't want to expose themselves to their moms and their dads and aunties. So what we're doing is in all our referral hospitals and some district hospitals, we're putting in place youth-friendly services where a young person can actually go at the time that is suitable for them, and they will be attended to by staff that have been well trained to be able to know how to attend to this young person without the young person feeling uncomfortable. So it is actually a special target that we have in our plan. Thank you.
Jason Celeste says, I would like to know if the guidelines developed are developed in the context of COVID-19 pandemic. Angie, do you want to pick up on that one, please? When did you start developing these milestones and targets? Was it pre-COVID? It
was pre-COVID, and of course, many of the guidelines are based on evidence reviews, and evidence reviews go back to the literature. So most of the guidelines that are being developed now are actually looking at evidence from before the COVID pandemic period, let's say. But as we go along, we will be able to update them. We have a process in place now in WHO that we call the living guideline process. And so evidence comes in, we are able to update recommendations. And so in future, let's say, we'll be able to adjust as necessary.
Saroja, how has COVID impacted your work?
Definitely, as in the global level, in our country level also, COVID impacted, because our country also went in the lockdown, and in the first lockdown period, there is no clear instructions. So there are so many patients who travel to the health facilities, they are sent back to the home, and there is some confusion. So there is like second delay in reaching the facilities, and there is some maternal death because of that. And later, when health service providers, they advocated in that line, all the different professional societies and the individual experts, then the government come up with all those guidelines to not to stop all those clients and the women for reaching the facilities. Then it become a little bit easier. And definitely in the first lockdown, it was a very difficult time in the peripheral level with the health service providers. They are also confused, how they will provide the services and whom they should call. Like there is a risk of getting infected in the facilities. So so much of confusion was there. Gradually, when the government level, they started RMNCH subcluster and cluster meetings, and the partners and the government and the societies, they went along with all the service providers to continue the RMNCH services throughout the country in the national and subnational levels. So after that, it became a bit easier, but still, we have some issues regarding the vaccination of the pregnant woman, and we are advocating for that in the government level also, and hopefully we will get permission for the vaccination of the pregnant woman. So I think we are also facing so many issues regarding these services in MNH due to COVID.
Okay, we have an implementation question here. Robin, I'm going to ask you to share your thoughts on this question. One of the challenges we have had with the implementation of QOC standards is the heavy reliance on existing funding in countries, many of which are struggling, especially in the areas of HR and infrastructure. Will countries be supported to mobilize resources to address these critical gaps? That's a question that you might not necessarily be to answer, but the idea of having these standards and targets and then saying countries, there you go, how helpful is that? Are they actually able to then go from a great framework into implementation as far as funding is concerned?
So I do think that the funders each have their areas that they fund, and I think the coordination of donors is really important, and that should be driven at the country level. Within a country, it is up to the ministries, and in the case of infrastructure, it's not just the ministries of health, the Ministry of Health, Ministry of Finance, sometimes it's the Ministry of Education, depending on what we're talking about. But there needs to be coordination of the donors to make sure that these gaps are understood. I think that is a really critical role that we can support and kind of encourage and participate actively in. I do want to say that there are, in terms of the COVID, I think that we need to listen to the women, because we know that there have been disruptions, not just in services, but in their ability to come. I think also we need to listen to the midwives, because they have not been protected. They have been blamed. They are overworked. They are depressed. They are dropping out. I think we need to listen to midwives. And I think finally, there are a lot of digital innovations that are coming because of COVID. And I'm very, I want to make sure that we don't lose those. We don't just say, oh, COVID is finally, in several years, a little bit more a thing of the past. We can't go back to where we were. We must identify those effective digital innovations and build on those, because with that data, we can begin to understand and address the gaps that have emerged because of because of COVID, sorry. And I think that that's a piece that we need to make sure it doesn't fade away, but we build on it. So listening to the women, listening to the midwives, and building on the digital innovations of COVID.
Martina and Taria, I'm going to ask you to be brief. Martina, you start.
Yes, Robin, coordination is so important, country-led coordination. And I also want to add that when we are doing our national plans, our plans, we shouldn't stop just at the national level. It's important to go right to the top national level, for example, among the regions and even the districts. So any donor coming in knows what the challenges are in this or that health district or in this or that region, then you can conveniently choose to support the government, knowing what the challenges are there. Thank you.
Taria, briefly, go ahead.
I just wanted to quickly say that at country levels, countries must decide what their priorities are. Countries should decide what their priorities are. And those priorities should be what informs the conversation and how donors support countries to get their desired results.
Sylvia, this question, thank you, Taria. Sylvia, this question keeps popping up from a variety of our attendees. I'm going to use Eba's question here, though. What about girls below 15 giving birth? How can we include them in the targets? And also women living with disabilities. So maybe these are other areas where do the targets bring them in? Do the targets recognize that they are there as a demographic? Sylvia.
I think this question or this concern can be addressed under the equity factor, because in recognizing those who are vulnerable, the teenagers are one of the groups, the disabled, women living in hard to reach areas, women in conflict areas. These are the targets. So I think for countries, as we look at the milestones and look at addressing the equity gaps, we obviously will focus on this group of people. So all teenagers will be captured.
All right, very good. The inequity covers so many different areas. All right, panelists, I'm going to give you one more challenge, and that is in 30 seconds, tell me how implementation happens. Because hearing our conversation, you knew where the gaps You know where the gaps are, you know what needs to be done, but tell me about implementation. Is it being done? How that gets done? Will, you start very quickly.
Yes, we were surprised how much commitment we saw from the governments and countries that were part of the first batch and helping us with getting this done and also launched today. And I think the commitment and the accountability are very two important factors. And we found that there was a big vacuum that we're filling, and that's why I'm very confident in implementation.
All right, Nick.
A question for 30 seconds.
How's it getting done? Put me in charge.
No, I think, to all the points that everyone said, there's a need for greater collaboration and coordination across governments, across donors, across, and to incorporate the voices of women and frontline providers like midwives. But I also think there is this sort of need to be able to measure the progress along the way, and that means better data systems, better coordinated data systems as well. To be able to track that progress. Otherwise, you're not going to be able to, not just at a macro level, but at a micro level, to see how those improvements are really working, what's most cost effective, what's really going to improve quality of care.
Makes sense. Sylvia?
I think that as we developed the milestones, one of the first things you did, if you recall, remember from my slide, is ask for country input. And so that input was put in determining the kind of milestones we have. And I think we're going to it's going to promote country engagement and facilitate the implementation of the milestones.
Thank you, Sylvia. Alison.
Thanks, Femi. No, I just want to reiterate what other people are saying about coordination at country level and country priorities, and how can we as a community support those priorities at national, subnational levels, both for implementation and monitoring. Thank you.
Martina.
To add to what everybody has just said, in countries like ours, where you have several factors that influence negatively or positively reduction of maternal mortality, it's very important that everybody is involved. So the multi-sector approach, we should all think of bringing it around the table, because there are things that the Ministry of Health cannot do, which the Ministry in charge of women's empowerment, for example, can do better, or the Ministry in charge of more young people will do. So the multi-sector approach is key in implementation.
Robin.
I think everything has been said, but again, it's the having routine systems of using digestible data, and also making sure that data literacy at every level is a part of it. So building routine systems where consumable data is available to use, and that everyone feels it is their role to understand the data. Over.
Saroja.
It's again the shared accountability and the collaboration across the different stakeholders, policymakers, and the professional societies, community, and the service providers.
Turia.
Just to add my voice to a lot that has been said, I think we need to focus a lot on multi-sectoral partnership. A lot of those issues happen way before the woman is pregnant. And so we must look at implementation from a multi-sectoral lens. And in a lot of meetings, we say partnership, but it doesn't really translate to action. We must take that conversation and make multi-sectoral partnership a reality at country and subnational levels. Thank you.
And Franca.
Thank you. I think it would really help if healthcare professionals reflected the communities we serve, so that you see within the healthcare professionals the same communities that we're actually serving. And on top of that, I do think we need to be able to show how we are listening to women, context specific. Thanks.
Thank you, panel. Thank you for the engaging, interactive conversation. Thank you, attendees. You are spectacular. So many questions. I'm just going to point to Dr. Anshu Banerjee. He's available all day for your questions. All right, so let me move on, because now we want to know what are the next steps. Dr. Annika Knutson is the Chief Sexual and Reproductive Health Branch for the UNFPA. Dr. Knutson, thank you so much. What are our next steps? What should they be?
Thank you. And here's another excited midwives. So I really think that this launch is now, of course, coming to an end. But as we have heard from everyone, the work to accelerate, to end preventable maternal and neonatal deaths still lies ahead of us, a task really of proportion. But what I've also been excited to hear is that we have been very clear that we speak as one, we are determined, and together we have what it takes, I think. So when we now look to the future, and I could just say that there has been so many more next steps that have been formulated in these past hour and a half. But the more immediate next steps that I would like to really just highlight is that we really want to ensure that all the materials are available in the website and reach the governments and stakeholders at various levels. And I should have said that next steps is not just for some secretariat of EPMM or some management group or it's for all of us. These are all of our next steps. We also look to develop, and it's been mentioned by Will, a tool to track progress in achieving EPMM and ENAP milestones and targets, which will be extremely helpful for us to really see the progress. The next steps really belong together, because it's also been mentioned that we are now going to operationalize an in-country facilitation and coordination. But there was also a question from Myanmar and whether they were not included. And no country should feel not included. There will be this operationalization that is more direct in some countries, in the 19 countries. But what we also want to do is, of course, engage with the stakeholders in other interested countries to identify the gaps and needs for assistance. And here is an excellent opportunity to also have more South-to-South collaboration, to really learn from one another. So no one should feel excluded. WHO and UNFPA and other partners here in this launch work in country and have people in country that can really support. So that's what one of the other next steps is, engage with everyone. The one maybe big thing that we mentioned and talked about towards the end of this launch is really the need to advocate for mobilization of resources for maternal and newborn health. And we know that there are so many competing targets these days. And I think that many think that, but we have talked about maternal and newborn health for such a long time that we really should be done, shouldn't we? But we're not. We need to really mobilize for that last run. And we can't just do it by funding. We need to move from funding to financing. We need to look at innovative financing modalities. That's why it's so important that we are all here, donors, multilaterals, civil society, and private sector. So this is really something that we need to work on. We need to continue the alignment of maternal and newborn health at global level, at country level, and at regional level. And I think this launch really manifests something, a big step ahead. And I heard Dr. Sylvia say that every journey needs a landmark. I think this has been a landmark, but the other landmark are how we really materialize this at country level. So when we look forward, the joint EPMM ENAP progress report that we then see will happen in 2023 will be really another big landmark to say, we are finally here together. We have joined our agendas, and we know that without each other, we will not be able to deliver on this. And by that, I thank you with a really excited feeling from myself and from all people in UNFPA and WHO who really drive this partnership. Thank you.
Thank you. Dr. Austin Demby is the Honourable Minister for Health and Sanitation in Sierra Leone. I am delighted to say that he is here to deliver our closing remarks. Dr. Demby, Honourable Minister, the floor is yours.
Well, thank you very, very much, Femi. You've done a fantastic job moderating this very important session. Distinguished delegates, thank you for giving me the opportunity to provide closing remarks at this very important meeting. Every day in our lives, somewhere on this globe, what would have been a very joyous occasion, bringing a life into this world, becomes a nightmare for a pregnant woman, her unborn child, the family, and the nation. This is unacceptable, and we should address it with a robust determination to end preventable maternal mortality. Sierra Leone takes this very seriously and is proud to join other nations and our development partners in this clarion call to end preventable maternal mortality in our respective countries. We fully agree with the milestones and targets set, and we are committed to use these targets as floors, not ceilings, as we set our ambitious goals for our nations. We are inspired by the very bold targets historically set by WHO for their 3x5 campaign for HIV and AIDS, and by the UNAIDS 90-90-90 campaign. With such bold targets, we saw how nations rallied to meet and exceed the targets set. In Sierra Leone, as you know, the 2019 Demographic Health Survey indicated our maternal mortality rate as 717 per 100,000 live births, one of the highest in the world. As part of our national medium-term development plan, we intend to work towards reducing this number to 582 per 100,000 by 2023. At a Harvard ministerial meeting in Cambridge 2 weeks ago, I made a public commitment to reduce maternal mortality in Sierra Leone to an even lower number of 359 per 100,000 live births, 50% reduction by 2023. At such a pace, we have no doubt that we'll reduce maternal mortality to below the 140 per 100,000 live births by 2030. The focus of our approach in Sierra Leone is in 5 domains. 1, to prevent unwanted pregnancies, especially teenage pregnancies, by intensifying sexual and reproductive health education, while addressing the felt need of providing adequate contraception and commodities in user-friendly environments. 2, we want to significantly improve the quality of services provided at our 1,400 primary healthcare units in the country through intensive retraining of providers, including midwives, and expanded community healthcare workers, intensifying ENT services throughout the pregnancy, targeting at least 8 visits per pregnancy, identifying high-risk pregnancies early and referral for high-level care. This will involve improving obstetric and gynecologic infrastructure, equipment, drugs, and supplies for labor and delivery services to include post-delivery care. In that spirit, we'll launch a new app that would allow pregnant women to enroll in a program that provides geolocation of health facilities within their neighborhoods, allowing for constant support and exchange throughout their pregnancy. 3, we will intensify emergency ambulance referral services to ensure that difficult cases are referred in a timely manner to benefit from EMOC services at the district and tertiary hospitals. 4, we will invest in the numbers and quality of obstetric facilities at district tertiary hospitals to include staff, equipment, supplies, and appropriate medications. 5, and most importantly, we'll invest in intensive routine monitoring on a weekly basis. We'll constantly interrogate our data to put in place corrective actions while celebrating successful programs at the neighborhood, village, town, chiefdom, and district levels. With your continued support and national solidarity between high-impact nations, we are committed to change this narrative and bring back joy to our families as we end preventable maternal mortality in our respective countries. Thank you very much.
Thank you so much, Minister Demby. Thank you, panelists. Thank you, presenters. And most importantly, thank you, attendees, for your time, commitment, and many, many questions. The brief for this event will appear on the websites of the WHO and UNFPA very shortly. And this event was brought to you by the WHO and UNFPA. My name is Femi Oke. It has been a pleasure being your moderator. Thank you. Take care.
Thank you.
Thank you.
Thank you, Fanny. Thanks, everyone. Bye-bye.
Thank you.
Thank you.